Hello, everyone. It's my pleasure to share this talk with you today. So let me please introduce myself first. I'm Dr. Simon Sito from Hong Kong. I currently serve as an assistant professor at the Department of Ophthalmology at the Chinese University of Hong Kong. So today I'm going to share with you about the updates of ophthalmic gases in retinal surgery. I can see that there is a really big diverse of audience today from around the world. So I'm really excited about this talk today, and I hope that you will find this talk fruitful and learn something important. So first of all, I'd like to acknowledge my mentors, Dr. Zhang and Dr. Shahida Mohammed, and also the rest of my team members from the Hong Kong Eye Hospital. Well, now we all know that intraocular gas is commonly employed in a wide range of retinal surgery. When we're using expansile gases, it first undergo an expansion phase and then reaching the equilibrium, and gradually it got absorbed into our bloodstream. And commonly used intraocular gas include air, SF6, C2F6, and also C3F8. In the context of vitrectomy, we usually use the non-expansile concentrations, which varies according to specific gases. And in the context of pneumatic displacement or pneumatic retinopathy, we generally use a 100% expansile concentration of the gases. And the common indications for ophthalmic gases in retinal surgery include retinal detachment, macular hole, and submacular hemorrhage. You may argue that there may be even more extended indications of ophthalmic gases in retinal surgery, but due to time constraints, I will focus my talk today on these three specific common retinal conditions. Now, so we all know that ophthalmic gases are commonly used in fixing a variety of retinal conditions, but are there any caveats or limitations of intraocular ophthalmic gases? Well, first of all, we're reaching in the era of we're not just aiming to achieve retinal attachment in retinal detachment surgery. We're also hoping to achieve high integrity retinal reattachment. So in this study by from a prominent group from Canada, they show that intravitreal gas may actually increase retin displacement and also interdigitation zone disruptions compared to pneumatic displacement or compared to scleral buckling surgery. Moreover, the use of gas tamponade is associated with a wide range of inconveniences to our patients. For example, there would be a long period of visual rehabilitations, and especially when we use long-acting gases such as C3F8, the patient's vision will be impaired in the first 1 to 2 months after the operations. And the posturing is generally required. And as retina surgeons, we usually downplay on the inconvenience of posturing to our patients and we often like to blame them for not complying to our instructions on the posturing. But if you ask our patients, what is the single most important what is the most difficult part of the surgery? They wouldn't tell you that it's the surgery itself. They would tell you that it's the postoperative face-down posture that is the most troubling to them. That is the worst part of the experience in undergoing retina surgery. So posturing is actually a big problem for our patients, not for ourselves as surgeons, because we are not the one who need to adopt a face-down posture for a week. And also, our patients cannot travel by air until the gas is completely absorbed. Well, I personally live in Hong Kong, a small city. So to me and my patients, not being able to travel by air within the early postoperative period is not a big problem for them. However, globally, some patients, they may live in far away from tertiary eye center, and they may actually need to take travel by air to reach a tertiary eye center to undergo retinal surgery. And that could be a problem for depending on where you practice. And endotempionate agents, gas or silicone oil, they can cause IOP spike, which is generally tolerated in normal patients. However, in patients with pre-existing glaucoma, this is undesirable, particularly in advanced glaucoma patients. Postoperative IOP spike can cause a wipeout of their remaining visions. And like we already mentioned before, gas can contribute to retinal or macular displacement, And of course, it can also accelerate your cataract formations. And in my experience, the need for gas, the impairment of the early post-operative visions, and the requirement of post-operative posture really reduce the patient satisfaction. And by extensions, that would also reduce my own satisfaction as a retina surgeon. And we are getting also more increasingly aware of sustainability in medicine because of the global warming issues. And if you think about that, the gases that we use in ophthalmic surgery is potent greenhouse gases because they are fluorinated gases. So it is estimated that the CO2 emissions from ophthalmic gas over 5 years in the tertiary eye center needs we need to plant 14 trees per year for 100 years to offset the equivalent of such CO2 emissions. So you can see how big a problem it actually is to our environment. And although keeping up with environmental sustainability is not usually our primary objective of performing a retinal surgery, but if we put together all the surgeries we do globally over the world, together this may be making a significant difference. So is there a way that we can reduce the use of gas or at least limit the use of gas in retinal surgery? There are some updates regarding these three conditions, and I will go through it one by one. So the first conditions I would like to focus on is retinal detachment. So before I proceed with my talk, I want to know your preference. So what would be your preference in repairing retinal detachment in your practice? Would you prefer pars plana vitrectomy with gas or silicone oil tamponade, external approach with scleral buckle and circling band, or pneumatic displacement, pneumatic retinopexy? Right, I can see them as expected. The majority of the audience voted for pars plana vitrectomy with gas or silicone oil tamponade. And I entirely agree with you. In my practice, that is my most commonly performed procedure as well. But hopefully after this talk, when you come across suitable cases, I hope that you may take the time to consider whether you can offer buckling procedure or encircling band procedure or even pneumatic retinopexy for your patients. And why is that? Because we want to use the least amount of gases in retinal detachment surgery as possible. So the previous study is actually not a new study. It was a prospective randomized control trial published in 2019. So it was a randomized control trial comparing the efficacy and safety of primary pneumatic retinopexy versus pars plana vitrectomy. And although the conclusion is that in terms of primary surgical success rate, the pneumatic retinopexy group had significantly lower primary surgical success rate. However, in the end, in the intention to treat analysis, in the end, patients randomized to the PNR group, they had superior VA gait, superior visual acuity up to 12 months after the primary procedures, a higher visual function score, and also less vertical metamorphopsia. And how to account for this? How do we explain this? Because pneumatic retinopathy may cause less retinal detachment and cause less outer retinal folds compared to vitrectomy with gas tamponade. And why is that? Because during vitrectomy, when we perform gas flow exchange, we aggressively, at least I was taught that we should aggressively remove as much subretinal fluid as possible. And this violent removal of subretinal fluid is actually not it's not good for the reappositions of the outer retina to the RPE because the subretinal fluid absorbs too quickly and the outer retinal folds that may be present in chronic retinal detachment, it doesn't have enough time to unroll and reattach the retina and causing outer retinal folds, at least in the early postoperative period. Although eventually with time, most of these outer retinal folds generally resolve over time. But in this study by the pivot study group, they show that eyes with outer retinal folds in the early postoperative period, they tend to have a worse visual acuity in the long term. So this is something that we can consider in when we fix retinal detachment in the future, is to consider the integrity of the outer retina as well. And in pneumatic retinopathy, because we do not drain the subretinal fluid and rely on the RP pump to pump out the subretinal fluids gradually in a slow manner, slow and controlled manner. And in that case, the outer retina reattach the underlying RP in a slower manner, and that may this gradual process may cause less outer retinal folds and also less retinal displacement. So you can see in the bottom pictures that eyes show the bottom left picture shows that there is a retinal displacement in an eye treated with pars plana vitrectomy. Under fundus autofluorescence, you can see the slightly hyper autofluorescence line highlighted by the white arrow here is the original positions of the retinal vessels, while the black line here is the final positions of the retinal vessels after the surgery. And such phenomenon is not as commonly observed in eyes treated with pneumatic retinopathy. And what about sclerobuccal versus vitrectomy? So as expected, sclerobuccal is associated with less displacement, less retinal displacement compared to vitrectomy. This is again likely due to the speed of subretinal fluid absorptions. Because when we perform sclerobuckling, even if we do external drainage of subretinal fluid, we cannot drain it as quickly or as thoroughly compared to vitrectomy with under gasflow exchange. So when we perform buccal at the again because and it's not commonly that we can drain the SRF until the retina is completely dry, even if we want to when we do external SRF drainage. So that may explain why in eyes treated with scleral buckling there tends to be less retinal displacement. But what about if we look at scleral buckling alone? So the pivot group also show that when we do external drainage, there will be more retinal displacement when compared to when we do not do subretinal fluid drainage. So in fact, I think there's a paradigm shift among retinal surgeons to do less external SRF drainage when we are doing external RD repair. But it's but it may not always be possible to avoid external subretinal fluid drainage, especially in very bullous retinal detachment. If you do not drain the subretinal fluids, it's really hard to localize the retinal tear, and it would be really hard to determine where you should put your buccal because of the parallax effect of the that will make the retinal tear look more anterior than it actually is under a bullously detached retina. So I would say that external drainage may not, we still need to perform external drainage in certain cases. For example, very bullous retinal detachment. So with that in mind, I would like to know the audience preference in what is the most important considerations in repairing retinal detachment in your practice. Is it single surgery success rate, the integrity of retinal reattachment, the degree of displacement, or the invasiveness of surgery? Right. Well, awesome. It's quite surprising that to me that almost half of you shows that the integrity of retinal reattachment is the most important considerations. So it means that most of you have been paying good attention to what I just talked about. Uh, but I would like to argue that in my practice, actually, single surgery success rate is my personal most important considerations. I understand that it varies from culture to culture, and it also depends on where your practice is, what is the culture in your practice, in your geographic locations. In Hong Kong, I would say that our patients are generally quite unhappy when we tell them that they need reoperation. So although in my mind, I know that scleral buckling or pneumatic retinopathy may lead to less retinal displacement or better integrity of the retina. But I would say in my personal practice, single surgery success rate is still my number one priority. But if I come across suitable cases that, for example, a single tear superior retinal detachment, in these cases, I know that pneumatic retinopathy can have a very high or comparable success rate with vitrectomy. Then in these cases, I would let the patients know that the success rate is relatively high, and this practice actually, on average, can lead to better visual acuity in the long term. And also because the waiting time for retinal surgery in my center is quite long. So if I perform pneumatic retinoplasty in one patient and let's say 20% of them redetach, that means there would be 20%. And assuming that the success rate for vitrectomy 10% is 90%, that means that there would be a 10% increase in redetachment rate and leading to even longer waiting time for retinal surgery. So I'm glad that uh, over half of you would think about the integrity of retinal reattachment in your practice in the future. So this is an important point to remember after. I hope that this is something that you will consider after today's talk. All right, so in summary, regarding retinal detachment, pneumatic retinoplasty may lead to higher integrity retinal reattachment compared to vitrectomy. But we also need to remember that the primary surgical success rate is also lower. So we need to consider all aspects and all of these points when we determine which surgery we offer to our patients. Sclerobuccal, as expected, also less retinal displacement compared to vitrectomy, and external drainage may increase the risk of retinal displacement. So all in all, these studies reminded us that it is not important to completely drain all of the subretinal fluid, as it may not be, it's not only that it's not necessary, it may even increase the risk of outer retinal flows and also retinal displacement. And as surgeon, it's our duty to educate our patients that it's actually better to be patient and give time for the subretinal fluids to slowly reabsorb by the RPE pump. So the take-home message should be we should consider using buccal or pneumatic retinoplasty in appropriate cases, as long as you believe or you're confident that you can maintain a reasonable high surgical success rate because of all these potential advantages of buccal and pneumatic retinoplasty. And most importantly, if we do not do buccal more, I already have a feeling that the new generations of retina surgeons in my hospital, they're losing the art and skill of performing buccal, because buccal is buccal is to me at least in the initial learning phase is more difficult to master compared to vitrectomy, because in vitrectomy you can see everything. You can see the whole retina, you can see where your indentation is, you can see where the retinal tear is when you perform the surgery. Whereas in performing sclerobuccal, you have to be very skillful with your indirect ophthalmoscopy skills, and you have to be very skillful in marking where the exact locations of retinal tear. So if we do not perform buccal even in appropriate cases, very soon this surgical skill will be lost in our future generations of retina surgeons. And the pivot study group also proposed alternative when you really need to perform vitrectomy. For example, you feel that there is a lot of vitreous tractions that cannot be addressed by buccal or pneumatic retinoplasty. They propose that you can do a so-called minimal gas vitrectomy, whereas after performing the vitrectomy, you deliberately leave the retina detached with no air fluid exchange performed. And you close all the wounds and then you inject expansile concentrations of SF6, followed by postoperative positioning, and you just give time for the SR to slowly reabsorb by the RPE pump. So some food for thought for you, but personally, I'm not brave enough to try this procedure myself. Okay, so that's it for retinal detachment. So in retinal detachment, I spent most of my time talking about studies from other groups. And in the remaining two topics, I will share more data from our group's own research and own experience. So macular hole, suffice to say, is one of the most common surgical macular conditions that requires prompt surgical interventions. Otherwise, the patients can have irreversible vision loss. So typically, macular hole is treated with vitrectomy with peeling of internal limiting membrane, followed by gas tamponade or silicone oil tamponade in certain cases, and postoperative face-down posture. And the surgical success rate is typically very good. And again, face-down posture might be a good idea if after a full day of clinic or surgery, when you're very tired, you might be longing for a massage. But if I ask you to lie face down for to 5 days, I'm sure most of you will feel quite blue about it. So when I was a trainee, my mentor taught me a few myths that now I know that it's not entirely true. First of all, they taught me that I need to peel as much IOM as possible. The more, the better. The wider IOM I peel, the better. And secondly, one of my mentors taught me that prone position is a must. In fact, he half jokingly taught me that he would always use the longest possible intraocular gas, in that case, which means C3F8. And he will always tell the patients that you need to maintain a face down posture for the entirety as long as the gas remains in your eye. And he taught me that because in that case, even if the macular hole failed to close, you can blame it on the patient that their compliance is not good enough. Of course, he was joking to me, but this is when I first entered training, this is what was taught to me. And also, long-acting gas can increase success rate. That was the concept I got from some of my mentors. But we now know that it's not necessarily true because there were a lot of studies showing that inverted IOM flap or temporal IOM flap may increase the macular hole closure rate in challenging cases, for example, large macular hole or chronic macular hole. So another question for the audience. So what is your preferred technique in macular hole repair? Would you like to perform wide ion peeling, inverted ion peeling, so inverted ion flap, or single layer ion flap, such as temporal ion flap? Right, I can see that almost half of the audience voted for wide ion flap, and in the remaining half, it's almost a quarter of them voted for inverted ion flap, and a quarter of them voted for single layer ion flap. Right, so great, thank you. So just a brief introductions on inverted ion flap. Inverted ion flap. In inverted ion flap technique, we deliberately leave the perifoveal IOM unpeeled and then use it to plug it on top of the macular hole or even inside of the macular hole. And in temporal ion flap, we only peel the temporal IOM and then we use it as a flap to cover the macular hole as a single layer, preferably. So why temporal ion flap but not nasal, superior or inferior, you may ask? Because ion peeling can cause iatrogenic damage to the retina, particularly in inexperienced hands. So by performing a temporal ion flap, we can avoid damaging the papillomacular bundle. So the inverted ion flap technique has been shown to have high closure rates in large macular hole compared to conventional wide ion peeling. However, I usually do not I try not to perform inverted ion flap technique nowadays because it may cause excessive foveal gliosis, especially if you do the tuck-in technique where you tuck in the ion flap inside of the macular hole, that may potentially increase the risk of foveal gliosis. And in the temporal ion flap technique, because we peel less IOM, there will also be less downfall, which stands for dissociated optic nerve fiber layer, and we preserve the papillomacular bundle. In fact, in this study from Taiwan, they show that IOM flap has less foveal gliosis and better visual acuity up to 6 months compared to conventional peeling, while maintaining comparable anatomical closure rate. So we now know that peeling as much as IOM is not necessary in closing macular hole. In fact, when we see challenging macular hole, we may want to do inverted IOM technique or single layer IOM technique. What about prone position? Is it really a must? Okay, so another vote. So would you mandate your patients to adopt face down posture after a macular hole surgery? Right, I see 83% of the audience voted for yes. So they would routinely instruct the patients to adopt face down posture. So in fact, when I repair macular hole with gas or silicone oil, that's my practice as well. But so to speak, it is not necessary. Face down posture is not necessary in after macular hole surgery. So I really admire this this group of investigators. So they performed a randomized control trial to compare the macular closure rate using face-down positioning and also face-forward positioning. So there was no significant difference in the rate of macular hole closure between the two groups. However, one may argue for the use of face-down posturing because from this RCT, the postoperative vision was significantly better in the face-down positioning group. So even though face-down posture was associated with a better postoperative VA in this group, the macular hole closure rate, which was the primary objective, was not significantly different. So even if one believe in the benefits of face-down posture, it is not one should not be rigid about it. If the patient can tolerate it, great. If the patient really cannot tolerate face-down posture for whatever reason, breathing difficulty, neck problem, neck pain, back pain, or medical conditions that stop them from adopting a strict face-down positioning, we need not to be rigid about it and to to force our patients to adopt a face-down posture. So the second myth is also busted. Post-operative face-down posture is not a must. What about gas? Is a longer acting gas the better? So what if I tell you that not only that we do not need longer acting gas to close macular hole, we can actually close macular hole without using gas at all. So how can we perform it? So in these patients, I first use, sorry, let me go back to the start. I first use beryllium blue to stain the RM. As you can see, there's a large macular hole. And then I perform a temporal iron flap as usual. As you can see, I create an iron flap from the temporal macula, covering the macular hole. And then I use heavy liquid PFC to unroll the iron flap and stabilize it over the macular hole. Make sure that the entire iron flap is covering the macular hole. And then underneath the PFC, I would inject dispersive viscoelastics to act as a glue to adhere the iron flap to the retina. And finally, I remove the PFCL. As you can see, the iron flap adhere very nicely over the macular hole as a single layer flap. And then you can see the macular hole close very nicely over 12 weeks. So longer acting gas is not necessary to increase success rate. In fact, it is not necessary in closing macular hole at all. So there are a lot of advantages of omitting gas because faster rehabilitations, no restriction of air travel. We can perform OCT images on day one, which I will show you later. And also, it may potentially cause less macular displacement. We don't know that yet, but we can look into that in future studies. So does this technique work for complex macular hole? Does it work for pathological myopia with myopic tractional maculopathy? And does it work for macular hole associated retinal detachment? So we perform a retrospective review of 24 cases of complex macular hole that underwent this SAT technique. We define complex macular hole as large macular hole, high myopia associated macular hole, or chronic macular hole. From a cohort, you can see that the mean basal linear diameter was very large. It was 951 micron. The minimal linear diameter was 534 micron. And we have so 95.8% of our cases classified as large macular hole. And 37.5% of them were macular hole associated with high myopia. And we achieved macular closure rate in 100% macular closure rate in all 24 eyes. And the eyes exhibit a significant improvement in visual acuity postoperatively. As you can see, this very large macular hole, we can perform a very nice postoperative day one OCT. You can see that this is the appearance of a single layer iron flap over the macular hole on postoperative day one. And because there's no gas use, we can obtain a very good quality OCT images even on postoperative day one. And by month 3, the macular hole closed. And you can also see this case of high myopia patients with posterior staphyloma and also full thickness macular hole. Again, on day 1, we can already see that there is an iron flap connecting the edges of the macular hole. And by month 3, the macular hole completely closed. Again, another cases of high myopia with posterior staphyloma with dome-shaped macula. Again, on day 1, you can see that there is an iron flap crossing the bridges of the macular hole. And then by 1 week, it almost entirely closed already. So the other advantages of not using the gas is that in the early postoperative period, the day 1, week 1, we can already get good quality OCT images. And that is very rewarding to us as retinal surgeon. And then we can also show these OCT images to our patients that, look, your macular already closed. And they are very happy about it. And because they don't need to adopt postoperative face-down posture, because there's no gas, they can immediately on post-op day 1, they can at least have on average 0.1 to 0.2 visions. Though on average, from my experience, the patients are very satisfied with our service with this surgery. So we recently published our data in Retina towards the end of last year. Okay, so we show that this technique works for complex macular hole. What about high myopia with concomitant macular hole with myopic tractional maculopathy? Would it work? So you can see this is a large macular hole in the high myopia patients with MTM. So in high myopic patients, I always use IVTA to assist the PVD inductions. In high myopia, you have to be very lucky to not need to perform the PVD inductions. And then I proceed to the temporal RM peeling as usual. I first peel a crescentic shape of IOM in the temporal macula, and then I fashion the remaining IOM as a flap over the macular hole. You have to be very patient in myopic patients because the IOM tends to break very easily. And then I use PFCL to unroll the IOM flap and then stabilize with sub PFCL viscoelastics. How does it work? Well, it works beautifully, in my opinion. Again, on day 1, you can see that, of course, there would be residual retinal schisis. But again, we can see a nice iron flap over the macular hole. And by 1 week, you can argue that the macular has closed already, although it takes time for the foveal detachment to gradually resolve. But mind you, that's only the postoperative week 1 OCT. And I have another similar case which also worked beautifully. This is another case with MTM and also macular hole. And you see that by week 4, the macular hole closed already, and most of the macular schisis resolved. Well, I would argue that in MTM, the macular schisis, even with or without gas, even when you use gas, sometimes it takes 3 to 6 months or even up to a year for the schisis to be fully absorbed. So I would argue that by omitting gas, we are not actually delaying the recovery of the macular schisis. And I know that we cannot directly extrapolate the results from people study to macular schisis, but at least now that we know that it's not always, we do not have, as retinal surgeon, we do not have to be impatient about intraretinal fluids or subretinal fluid after retinal surgery. It might actually not be a bad idea to let the intraretinal schisis fluid or subretinal fluid to gradually reabsorb on its own. And the last question is, does this technique work for macular detachment? So we try to use less gas or no gas at all in repairing retinal detachment. Can we do that for macular hole retinal detachment? This surgery was performed by my mentor, Dr. Zhang, because I myself am not brave enough to attempt this yet. So this is a subtotal macular hole retinal detachment. Again, we use triamcinolone to ensure that all posterior highlight is peeled away from the macula. And then RM staining. So if we want to perform this technique, we need a flat macula. So in this case, we'll first perform airflow exchange to drain the subretinal fluid through the macular hole first. And then we put the PFC over the macular hole and then we inject BSS again and then we will perform the iron pulling under BSS and underneath the PFC. As you can see from the intraoperative OCT, we can see the iron flap covering over the macula nicely. And I just want to guide you through the challenging part of the surgery again. So first we have to drain the SRF under air, and then we inject PFC to cover the macular hole, and then we re-inject the BSS instead of air. And then now we have a reattached posterior pole, and then now we can perform the iron peeling under the PFCL with the aid of RM blue. It is not easy, so I'm not suggesting that you should do it. I'm just suggesting that this is an alternative way to repair macular hole retinal detachment. And voila, on postoperative day 1, you can see that the retina miraculously reattach without the use of gas. And then we can also see that the macular hole is starting to heal. So the iron flap without gas tamponade technique is actually a very robust technique that works across a spectrum of simple macular hole to complex macular hole, and also pathological myopia and or even macular hole associated retinal detachment. So in summary, this is a good technique, and also the patient's satisfaction is really good, and also it's also highly rewarding as a retinal surgeon to be able to repair macular hole without using gas at all. And finally, I would like to talk about the third and also last conditions that I would like to cover today, submacular hemorrhage. So before I proceed to my talk, so I would again like to know your thoughts and practice on how you would manage massive submacular hemorrhage. So for example, if you see this patient with these presentations of massive submacular hemorrhage with the subretinal clot extending beyond the arcade, would you offer these patients anti-VEGF monotherapy, pneumatic displacement with or without TPA, or pars plana vitrectomy with subretinal injections? Okay, I can see that the results are quite even. So approximately 1/3 voted for anti-VEGF monotherapy, 1/3 voted for pneumatic displacement with or without TPA, and 1/3 voted for vitrectomy. So for submacular hemorrhage, it's not easy to design a unbiased randomized control trial because the presentations can be very variable. And also, for example, in my part of the world, in Asia, we have more polypoidal choroidal vasculopathy compared to neovascular AMD, let's say in the Caucasian population. So in my practice, we do actually see submacular hemorrhage quite often, like maybe 3 to 4 cases per week. But the presentations can be very variable. It can be like from a 3 to 4 disc diameter of hemorrhage within the macula, or just beyond the arcade, or in the most severe cases, it can be causing breakthrough vitreous hemorrhage or even exudative inferior retinal detachment. So it's really hard to give a simple answer on how best to manage submacular hemorrhage. But fortunately, as retinal surgeons, we have a lot of options that we can offer to our patients nowadays. And I'll go through that in the remaining of this talk. So why do we need to surgically displace submacular hemorrhage? Why do we not just all do intravitreal anti-VEGF monotherapy? It is because that toxicity, irreversible vision can occur within 2 weeks, and toxicity may occur as quickly as 24 hours from the direct barrier effects of the submacular clot, the tangential mechanical shearing force, and direct heme toxicity. So that's why in my practice in Hong Kong Hospital, we are quite trigger happy. We do like to surgically displace the submacular hemorrhage. So there are mainly 3 components that we can inject in the eye to displace the submacular hemorrhage. Gas, pneumatic displacement. By injecting expansile gas, we ask the patients to adopt a face-down posture. And with the buoyancy of the surface tension of the gas and buoyancy of the gas, with the surface tension of the gas, we hope to counteract the buoyancy of the subretinal clot and cause inferior displacement of the submacular clot. We can also consider injecting intravitreal TPA, tissue plus miniature activator, to increase the clot liquefaction rate. And of course, after all, we need to treat the underlying causes of choroidal neovascularizations by injecting anti-VEGF agents. Well, generally, we do the injections of these three agents in the intravitreal cavity. But recently, with 41 gauge subretinal needle, all three components can be injected in the subretinal space as well. So it may sound crazy to you. Why would I want to ingest subretinal air or subretinal? It makes sense to ingest subretinal TPA because there were concerns that intravitreal TPA molecules may not be able to penetrate from the vitreous cavity through the retina into the subretinal clot space. However, is there a rationale that we need to ingest subretinal air or subretinal anti-VEGF agents? So this technique was actually first proposed by Martel and associates around over 10 years ago already. So it works by manipulating the three forces that dictate the movement of subretinal clots in the subretinal space, namely the upward buoyancy force, the downward gravity, and also the friction that stop the subretinal clot in moving in any directions. So the subretinal TPA can improve the clot liquefaction rates and decrease the frictions by creating a subretinal bleb. The anti-VEGF together with the TPA, of course, increase the subretinal bleb volume and decrease the frictions and make it easier for the subretinal clot to move in any directions. And also by directly applying to the choroidal neovascularization lesion, you may argue that the anti-VEGF can be more effective. In fact, it was shown by a group from Argentina that subretinal anti-VEGF injections may lead to less burden of subsequent injections compared to intravitreal anti-VEGF injections. And lastly, the subretinal air reduced the buoyancy of the clot by as much as 830 times. It also improved the oxygenations of photoreceptors, and it acts as a lock to allow mixing of the TPA and anti-VEGF. So in our practices in Hong Kong Eye Hospital, we do both pneumatic displacement and subretinal cocktail injections. When we do pneumatic displacement, we like to use 0.3 ml pure C3F8 with or without intravitreal anti-VEGF or TPA, and usually followed by prone posture. When we perform subretinal cocktail injections, we inject 50 microgram in 0.4 ml of TPA and 0.05 ml of anti-VEGF, and also 0.2 ml of filtered air. And at the end of surgery, we only do 50% of gas flow exchange. And postoperatively, the patients, instead of face down posture, we actually ask them to sit up. As you can see, this technique works beautifully in displacing macular hole. As you can see in these patients with medium-sized macular hemorrhage, there was a complete displacement of the submacular hemorrhage and complete, you can see that the postoperative OCT is very nicely that you can see no residual subretinal clot or subretinal fibrotic scar. This is another case of massive submacular hemorrhage treated with the same technique. As you can see, most of the submacular hemorrhage has been displaced inferiorly to beyond the arcade, and the foveal depressions nicely reappear with no foveal involving subretinal scarring or fibrosis. So how do we do it? So this is a case of submacular hemorrhage. Again, in specific case, we may need to induce the PVD. As you can see, subretinal injections of the TPA and anti-VEGF creates a very nice subretinal bleb, essentially creating a retinal detachment. And then we inject the subretinal air, followed by partial gas flow exchange. And by postoperative 1 week, you can see that the submacular hemorrhage has been completely displaced and the foveal depressions reappeared. And there's no foveal involving subretinal clot or subretinal scar. This is another case of massive submacular hemorrhage. Again, you can see a very nice subretinal bleb as we inject the subretinal TPA and also subretinal anti-VEGF, followed by subretinal air injections. So you may ask, there has to be some benefits of subretinal cocktail injections to justify performing such an invasive and surgically challenging procedure. So I've spent the first two-thirds of my talk trying to convince you to use less gas. But in the third part of my talk, I'm actually trying to convince you to inject, not only to use more gas, but to inject the gas in the subretinal space. So there has to be some benefits of this procedure to justify such a invasive technique. So pneumatic displacement, of course, is a shorter operating time. It's also minimally invasive. It doesn't require any specialized surgical equipment, and it can be performed by competent trainees under supervision. But subretinal injections require subretinal injection needle, which is a specialized equipment not readily available in most centers, and it usually done by experienced vitreoretinal surgeons. I would be comfortable letting my competent trainees to do the pneumatic displacement, but I don't think I'll let inexperienced retinal fellow to do the subretinal cocktail injections myself. So now let's look at some data and see whether it's really worth it to do the subretinal cocktail injections. So we performed a retrospective comparative study. And of course, because of the retrospective nature, the two groups differ in baseline characteristics. You can see that the submacular hemorrhage tends to be worse in the subretinal injections group. They had more extensive submacular hemorrhage. They have longer durations of symptoms before the surgery and higher mean central subfield thickness before the surgery as well. And also, the proportions of PCV is less in the subretinal injection group, but this may be due to the underestimation of PCV because usually after massive bleeding, the polyp would regress, spontaneously regress. So this may be a bias. This may be a bias in our study. But despite these disadvantages, despite that the subretinal injections group had worse or more severe submacular hemorrhage at baseline, the postoperative visions was comparable at least up to month 6, and they all had a significant improvement in visual acuity compared to baseline. And needless to say, the CST reduction is greater in the subretinal injections group, and also the rate of complete foveal displacement or displacement to arcade or beyond is also greater in the subretinal injection group. And the odds ratio is up to 11.1 for foveal displacement and also 5.15 for displacement to arcade and beyond. And this graph shows that how the visual acuity gradually improved over time up to 6 months. Unfortunately, for the subretinal cocktail injections group, the visions dropped by 12 months. But I think this can be explained by the fact that they had more severe baseline submacular hemorrhage, indicating that the disease is worse at baseline. So this may explain why, in the long run, their visions would be worse compared to the pneumatic displacement group. But I'm not trying to sell it too hard on subretinal injections because there could be some unique complications that is not seen in the pneumatic displacement group, which is macular hole. So macular hole seems to be an unique complications of subretinal injections. As you can see in this case, so preoperative vision is 0.06. After the subretinal injections, although we successfully displaced the submacular hemorrhage away from the fovea, you can see that a full thickness macular hole developed. And fortunately for these patients, the macular hole closed after reoperation so with iron peeling and gas, and the visual acuity improved to 0.3. So there may be potential tricks to prevent macular hole formations after subretinal injections. First of all, we need to understand why can macular hole occur after submacular injections. It may be due to a blowout mechanism because we are stretching the fovea, stretching the macula at the weakest point, which is the fovea, by injecting a large volume of submacular fluid. So we need to be careful with our preoperative case selections. If the fovea is very thin, for example, in high myopia patients, we need to be careful. And secondly, we can modify our surgical technique by injecting the subretinal injections under PFCL the heavy liquid so that we can create a more diffuse and shallow bleb and minimizing the hydraulic stress on the fovea. And also, we can also adjust the volume of subretinal injections because one size may not fit all. So if you remember, so the injections of fluid we ingest is actually quite high. That's 0.4 ml of TPA, 0.05 ml of anti-VEGF, and 0.2 ml of air. But as I said before, submacular hemorrhage is actually a very diverse condition. Submacular hemorrhage can range from very small to very big. So maybe for very small submacular hemorrhage, we can inject less volume of TPA and a smaller volume of air to reduce the risk of macular hole formation. And other than that, other than macular hole, the rest of the complications profile were comparable between the two groups. So in summary, surgical displacement of submacular hemorrhage, no matter you choose pneumatic displacement or subretinal injections, can lead to clinically meaningful improvement in visual acuity. But subretinal cocktail injections had a greater chance of successful submacular hemorrhage displacement. And I'm not trying to say that we should perform subretinal cocktail injections in all cases because because that's not what I believe. But it can be used as a rescue operations in certain cases. For example, in our cohort, 2 cases, they actually underwent a primary procedures of pneumatic displacement, which failed to displace the submacular hemorrhage. And then they underwent subretinal cocktail injections, and then the SMH was successfully displaced. So my take-home messages for the audience today is that sometimes less can be more. And as a retinal surgeon, we should be familiar with not just one, but several surgical techniques to manage each retinal conditions and to suit the unique challenges and also unique patients' preferences. For example, we cannot let scleral buckle to become a lost art in the future generations of retina surgeons. So just to share a quote from one of my favorite book, it is called The Happiness Project. One of the most important quote from this book is that it's easy to be heavy, hard to be light. And when doing retina surgery, it's actually easy to do more in a surgery, but hard to do less while maintaining a high surgical success rate. And I would like to thank my mentors and good colleagues from the Chinese University of Hong Kong, the Hong Kong Eye Hospital Retina team. And that's the conclusions of my talk, and I welcome any questions or comments from the audience. Right, so I can see that there is some questions from the audience. The question was, how do you make the iron flap stabilize in macular hole surgery? Doesn't the viscoelastic gel move when the patient stand up? Okay, so in the macular hole with no gas technique, we first use a large, heavy liquid, the PFCL, to push down the iron flap underneath the macula. And then underneath the PFCL, we then inject the viscoelastic. So you can imagine that under heavy liquid, when we inject the viscoelastic over the iron flap, it actually disperses evenly like a glue over the iron flap. And then you wait for a few minutes. I usually spend this time to examine the peripheral retina or to perform or to implant the intraocular lens. And you wait for 1 to 2 minutes. And then even after removing the PFCL, you can see that the iron flap adhere to the retina very stable. You can turn on the infusion of the fluid and then you can try to move the eye around and the iron flap doesn't move at all. And we do not need actually we only need the iron flap to be stable across the macular hole only in the first few days because most macular hole heal within the first few days. And again, this is another perks of using this technique is that we can do OCT every day if you want in the first few days to monitor, to visualize how the macular hole close over the first few days of the surgery. Another question from Kian Kuat. Do you use intraoperative OCT to assist 41 gauge subretinal injections? And how do you inject without one? Okay, that's an excellent question. So in my hospital, we only recently have intraoperative OCT in the past 1.5 year, I would say. But the majority of the subretinal injections we performed were before that era. So that was before we have access to intraoperative OCT. So of course, with the aid of intraoperative OCT, that would be easier to identify the site of injection, but it is not necessary. So our trick is first, we need to select a site that is detached, okay? We do not want to inject over attached retina because the needle can puncture through the RPE, causing RPE rip or even choroidal hemorrhage. And usually we select the inferior retina where the retina is obviously detached. And that can minimize the risk of inadvertently puncturing the RPE, causing RPE rip or choroidal hemorrhage. And the other reason we choose the inferior retina is that the submacular hemorrhage always displays inferiorly, right? No matter what technique you use, the clot displays inferiorly, not superiorly. So by injecting inferiorly, we are inducing inferior retinal detachment, creating an inferior subretinal bleb, so that there is space for the subretinal clot to move inferiorly. But that is an excellent question. So it's always nice to have these gadgets by your side, like Batman or Iron Man. But like remember where Iron Man started from? He started from a cave. So with primitive equipments, we can also do great things in retina surgery. Okay, so another question is anonymous attendees that do you remove fish coat in macular surgery without gas? No, we do not remove the fish coat. In fact, it's it's almost impossible to remove the fish coat thoroughly uh under BSS in the fish's cavity because it's very dispersive. And secondly, we do not want to remove it because we want it to stay there as a glue to stick the iron flap to the retina. Another question from anonymous attendee is that if no gas in macular surgery, then do you place air or sealant after removing PFCL? Yes, we just leave the fissure cavity in balanced out salt solutions, and then we just close the wound as usual. So we just leave it in balanced salt solutions, yes. Without another question from Ramani, would there be less anatomical corrections? Right, so in our initial interventional case series, we were able to achieve 100% surgical success rate in 24 eyes with complex macular hole. So our hospital has been using this technique in the past 2 years, I would say 2 to 3 years or almost. So far, our surgical success rate is actually excellent. It's over 90%, which is comparable to conventional surgery. So I don't think this technique has to do superior or better than conventional surgery. It just needs to be even with conventional surgery to justify its use, because we are avoiding all the inconveniences and limitations of intraocular gas. Another questions from Mr. Bahauddin. So in retinal detachment, we might get retinal displacement in macular off cases. It will try all the SRF. Right, that's a good question. So when we talk about macular displacement after retinal detachment, we are usually talking about macular off retinal detachment. And it actually does not matter that much for macular on retinal detachment. That's an excellent question. And the second question is, do you prefer temporal IOM single flap even in average to small size macular hole? Again, that's an excellent question. I would say my preference over temporal IOM flap and conventional wide iron peeling varied during different phases of my journey as a retinal surgeon. When I first became an independent retinal surgeon, uh, performing temporal iron flap was very challenging and time consuming for me. So for small or medium-sized macular hole, when I know that wide iron peel can already have a very excellent surgical success rate, in those cases, I generally use wide iron peeling, and I generally reserve temporal iron flap for challenging cases. But then, when I reached the second phase in my journey as a retinal surgeon, I try to challenge myself. If I want to perform temporal iron flap in the most challenging cases, like high myopia with posterior sarcoma, I have to be very proficient in doing that. And then I try to practice temporal iron flap in every single macular case I see. So right now I've reached the equilibrium that for small macular hole I've reached the equilibrium that I do not need to perform more temporal arm flap to master this technique anymore. So now I I but now that I've moved on to mainly use no gas temporal, so to answer it simply, I usually use temporal arm flap, except when I'm teaching my trainee and I want them to know how to do wide arm peeling. In that case, I will teach them how to do the wide arm peeling instead. Okay, another question from Ms. Haley. What is the maximum duration of macular or retinal detachment you operated to have a future prognosis in your practice? All right. So I think for macular hole it's more forgiving. So in Hong Kong, although we should be classified as a at least middle to high income city, uh, in a public setting, in a public healthcare setting, we do see patients who present very, very late to us. But I think macular hole is more forgiving because I've seen chronic macular hole with symptom onset of over a year. Their visions can improve from 0.1 to 0.3 to 0.4 after surgery. So it's still not a very nice visual acuity, but to them, that's already a clinically meaningful improvement. For retinal detachment, it's harder to judge. Of course, it also depends on the extent of the retinal detachment. So sometimes for chronic inferior retinal detachment, if the patient is lucky, the SRF may be quite stable over time, and there could be still future prognosis even if we delay the surgery. But when the patients present with, let's say, chronic open funnel or even closed funnel retinal detachment with with a very long duration of symptoms, let's say over half a year, then we generally would advise them to undergo conservative management because in that case, surgery has a very low success rate and also very poor prognosis. There is no clear cutoff time for us. It's roughly 3 to 6 months in our practice, but there's no black or white cutoff in our practice as well. So there was one question from Rosa, which is not in English, so maybe Andy could help me to translate it later. And I can see more questions from Christina. So, okay, so the first question from Christina is that what's my technique in pneumatic displacement of submacular hemorrhage? So I assume you're asking about the simple the pneumatic displacement with the intravitreal gas. So in that case, we usually perform the procedures under topical anesthesia. We would first inject the TPA or anti-VEGF first because this is less likely to leak through the injection site. And we would leave the intravitreal gas injections towards the last part. So I would generally tilt the patient's head, ask the patients to look infranasally so that the supratemporal area is the most gravity independent area of the eyeball. And then we inject the gas vertically towards the center of the globe at the pars plana. I would keep that the plunger and then we inject it in a smooth and sustained manner to avoid fishing of the gas bubble. And I would hold my finger on the plunger as I remove the needle because if you remove the needle, if you remove the pressure of the plunger before you remove the needle, some of the gas may leak back into the syringe. So this is one trick that I feel helpful. And another trick to remove leakage, to reduce the leakage of gas is that before I remove the needle, I would move the patients from a tilted head to a upright head again, so that the gas bubble move away from the injection site and then reduce the risk of leaking through the needle site. And the second question is inverted flaps reserved for recurrent cases? Do I do it in primary surgery? So a simple question is that now I almost not for me for primary surgery I almost always perform the no gas tamponade technique nowadays. So The beauty of that technique is that, as you mentioned, as you can guess, is that there are still some residual ROM, particularly in the nasal area. So in the rare scenario that the macular hole fails to close, we can use the nasal ROM flap as a single layer flap or as an inverse ROM flap, depending on your preference. And for really recurrent macular hole, in our hospital, we still have other options. For example, autologous retinal transplant or platelet-rich plasma, where we take the patient's blood and then we put it in a centrifuge and then to obtain the plasma, which is rich in growth factors, and which can be applied to the macular hole. So someone very kindly translated Dr. Rosa questions. So it is asking me to clarify the percentage of recommended gas and whether they should be administered pure or combined with air. Okay, so it depends on what procedure we are talking about. So generally speaking, when we are performing pneumatic displacement for submacular hemorrhage or pneumatic retinopathy, we are injecting expansile gas because we want the gas to continue to increase the volume to increase the tamponade effect after we inject the gas bubble inside the eye. So in that case, we almost always use 100% gases. So it's either C3F8 or SF6. So SF6 it is and we generally want to achieve a final maximum volume of 1.2 mil. So for SF6, the pure form would expand to twice its volume. So because we want to achieve 1.2 mil final volume, so then we should inject 0.5 to 0.6 mil of SF6. And in our practice, we like to use C3F8 instead because C3F8 can expand to 4 times. So we only need to inject 0.3 mil C3F8. In my experience, in Asian eyes, it's very difficult to inject 0.5 mil of SF6 because it's Asian eyes, in my experience, are very prone to intra on-table pressure spike. You can see that even if you do anterior chamber until the anterior chamber is flat, it's really hard for me to inject 0.5 to 0.6 mil of gas inside the eye in Asian side. So in our hospital, we tend to use 0.3 mil 100% C3F8. But then there's another argument to use SF6 because as SF6 can reach the maximum expansion within a shorter period of time, around 24 hours. Whereas for C3F8, it takes around 72 to or even 96 hours to reach the maximal expansion. So for SF6, the expansion is more rapid and the tamponade effect is more rapid. So when we are doing vitrectomy surgery, we generally I'm talking about when we're doing vitrectomy surgery with full air fluid exchange. In those cases, we should use non-expansile concentrations of gases. So it's either air, 20% SF6 or 12% C3F8. Okay. So except when you're talking about I don't want to make it too complicated, except you're talking about vitrectomy with minimal gas vitrectomy as proposed by the pivot study group. In that case, after performing the vitrectomy, they do not perform gas flow exchange and they inject expansile concentration of SF6 afterwards. So I hope that answers your questions. What will be the management for a patient with macular on temporal retinal detachment of more than 6 months duration? Future acuity is good. Okay, so I also need to know the patient's age, the lens status. So for young patients, I try to do external approach as much as possible. Because in young patients, retinal detachment, usually, generally speaking, the posterior pitches detachment is not complete. So if you do perform vitrectomy in young patients, you have to if you have to induce the PPD, it's very difficult because in young patients, the features is very well formed. And there's also high risk of iatrogenic retinal tear during the inductions of PPD in young patients. So in young patients, if I see this case, I might consider performing a buccal or encircling band. And or even if it is temporal retinal detachment, you can consider pneumatic retinopathy and ask the patients to perform a lateral positions afterwards. I think both options would already give you a solid primary surgical success rate already. But if this is an old patient with persistent cataract, then for me, no brainer, I would go for uh, vitrectomy combined with cataract surgery. So the only problem is that you said the duration is more than 6 months. So for chronic retinal detachment, my feeling is that I would try not to do pneumatic retinopathy, although maybe not everyone would agree with me. Because the viscous chronic subretinal fluid would take a very, very long time to absorb, and it might actually cause problem with the retinal adhesions with cryotherapy or laser. So for in this case, for chronic retinal detachment, I either do buccal with drainage of the viscous subretinal fluid or vitrectomy. So you may say that, oh, you just talk about we shouldn't drain the subretinal fluid, but I don't think that only applies to acute retinal detachment, in my opinion. For chronic retinal detachment, because the subretinal fluid can be very proteinaceous, very viscous, and if you do not drain it, first of all, it's very difficult to localize the retinal tear correctly on table. Um, and that would also affect your surgical success rate. And also, if you do not drain it by external drainage or internal drainage, then it may take months for it to reabsorb. So for chronic cases, I do believe there's a role of SRF drainage, whether it's internal or external. Okay, so hope that answered your questions. Uh, Another question is from anonymous attendees that how do I choose the locations of subretinal injections? So I briefly talked about it uh, before. So without the help of intraoperative OCT, I usually choose the inferior retina where it is most bullously detached. So that's the safest part to do the subretinal injections, because if it is detached, then there would be less risk for your subretinal needle to puncture the RPE, and there's more room for your TPA and also anti-VEGF solutions to create a subretinal flap. And if intraoperative OCT is available in your operating theater, that would also be an excellent choice. Okay, and a question from Taha. So what are the side effects of silicone oil? So silicone oil, if removed timely, they generally are quite safe to use. But maybe some of you may agree with me. For example, in my setting, in public hospital in Hong Kong, sometimes patients need to wait for a long time for silicone oil removal. Textbook teaching is that we should remove it around 3 to 6 months after the primary procedure. But in a public setting, sometimes patient may need up to a year after, or even more than a year after the primary procedure to remove the silicone oil. So in this case, we do see some emulsification of silicone oil quite often. And once emulsified, it's very difficult to remove completely. And if the emulsified silicone oil migrate to anterior chamber, it can also cause glaucoma, which could be problematic. And if you delay the removal, even if you remove the silicone oil, sometimes the silicone oil can cause permanent damage to the trabecular meshwork, and the IOP spike may be irreversible. And also, long-standing cases can also cause band keratopathy, uh, uveitis, and also in phakic eyes, of course, it would accelerate the cataract formation very quickly. And because of that, in my practice, I try to avoid silicone oil in phakic eyes as much as possible, unless I have no choice. But in my experience is that once you use silicone oil, it's almost certain that the patients will develop cataract in the next 1 to 2 years, and they may require cataract surgery regardless in the end. Yeah. Another question from Sarah is that whether I use cohesive or dispersive viscoelastic for the macular hole surgery. I would use dispersive viscoelastics. Yeah, because dispersive viscoelastics is more, it sticks to the retina better. Okay, so I use viscose. So similar to why we use physical in cataract surgery, because it coats to the corneal endothelium better. So because of the adhesive nature of dispersive viscoelastics. Okay, so another question, a very valid question, is there any chance of high OP due to leftover viscoelastics in macular surgery? Uh, the answer is no. Actually, I would argue that the use of gas tamponade would cause more IOP spike. And the fact that because we are not injecting the viscoelastic in the anterior chamber, and so most of the viscoelastic should remain in the posterior chamber, at least in theory. And even if you have a one-chamber eye, even if the patient is aphakic, or have a very large iridodialysis, or have a very large peripheral iridectomy, as long as you do not ask the patient to lie in a face-down position, the viscoelastic should not be able to migrate to the anterior chamber and cause IOP spike. So I would actually argue that it's more likely for the patients to have transient hypotony than transient high IOP using the no gas tamponade technique. Especially in high myopia patients, even if you suture all wounds nicely, because of the poor scleral rigidity, it's not uneasy for them to have transient postoperative hypotony. Right. So I hope that answers your questions. Uh, Another question from anonymous attendee is that, what about post-op subretinal fluid? How to manage? So I assume this question is referring to retinal detachment. So I think the lessons that I personally learned from the series of previous studies is that we actually do not need to worry too much about postoperative subretinal fluid, as long as it is not on an increasing trend. We can be rest assured that with time it will resolve, as long as we do as long as it is not on increasing trend, and as long as that we can be sure that the primary tear has been nicely laser or cryo and be adequately tamponed by either a buckle or gas. Yeah, but I understand what you're talking about, because for me, I also prefer doing vitrectomy with gas exchange, because as I explained before, in my locality, in my practice, I would say single surgery success rate is my number one priority. And as a retina surgeon, we always the feeling of getting a dry retina on table is quite reassuring to ourselves. So I understand your questions that sometimes as a surgeon it might not be nice to see residual fluid, but I think the lessons that we learned from the series of previous studies is that it is actually okay. It is actually more safe than we thought to tolerate some postoperative residual fluid. Another question is that from anonymous attendee is that, how long the patient need to avoid air travel after surgery with gas tamponade? So I would say until the gas, no remaining gas in the fish's cavity. Yeah. So so depends on which gas you use. For air, it should be approximately a week. For SF6, it's approximately 2 to 4 weeks, and for C3F8 is 6 to 8 weeks. So do the gas need to be replaced from an other anonymous attendee? So no, we do not need to replace the gas. We just wait for the gas to spontaneously reabsorb. When we need prolonged tamponade agent, we use silicone oil instead. And if you have any more questions, feel free to send an email to me. I would be happy to clarify it, like in person.